Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree Chappell, host and managing editor of Top Med Talk, and we are here in beautiful Raleigh, North Carolina at Wake Med for a conference that we're attending for enhanced recovery after cardiac surgery. And I'm joined today by Editor-in-Chief of Top Med Talk, Monty Mythen. Hello, Monty.
Yeah, it's great to be here, isn't it? Back in sunny North Carolina.
It is. It's beautiful. This is kind of your stomping grounds.
Well, I spent a bit of time here back in the day.
Yeah.
Used to work at a place up the road. We're at Wake Med. I used to work at a place up the road called Duke.
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 Oh, Duke.
Yeah. It's got 3 O's and a K in it. But anyway, moving on. That's an old story.
So, Monty, tell us about what we did last night.
Well, we had a special dinner symposium as part of a 2-day event that's been taking here at a place in Raleigh, North Carolina. We were at a hotel up the road, the Sheraton in Raleigh, where we had a dinner attended by about 150 enthusiasts in the world of cardiac surgery. It's a little sort of launch event, the relatively recently formed Enhanced Recovery After Cardiac Surgery. We had the inaugural president there. We had a number of members of the board there. Everyone was so engaged. We were talking that in an earlier podcast, is in the cardiac world, it's a relatively small tribe, and they engage with each other with energy and enthusiasm. There's no shortage of opinions.
This is good, but all right, however you look at it. But I thought it was great. I thought it was a really wonderful evening. There's been a lot of buzz about it, and so we're here today at Wake Med.
Yep.
For the second kind of part of
they've been designated the ERAS, Enhanced Recovery After Surgery, now global society has this subsections now of different subspecialties, colorectal being one of the early ones, but now if you look into their website, the ERAS website, you can find that there are various different subsections which was referred to, but there wasn't a cardiac one before. Right. So as I understand it now, there is a cardiac ERAS subsection. That's what we were talking about at the launch last night, and Wake Med is one of the first centres of excellence, and it's a centre of excellence training programme here today, which is why we've got so many global experts have come to join us.
That's right. And so our special guest that we have sitting down with us today is actually one of those experts. I'm Dr. Seenu Reddy. He's the Surgical Director of Structural Heart Program and Cardiac Surgical Outreach at Centennial Heart and Vascular Center, which we're going to have him tell us more about where that is. But I'm also the Director of Industry Relations for the Enhanced Recovery Cardiac Society. Seenu, thank you so much for joining us.
Great to be here, and thanks for the invitation.
And thanks for last night.
Yeah.
Star performer.
It was great. It's a potpourri of great ideas and enthusiasm, and it was just wonderful to see like you said, the energy in the room.
Yeah, it really was.
And you did a great job in calling your team out early on, so you got them to do the work.
You did. I noticed that.
Well, that's the part of enhanced recovery, right? It's a team effort.
Yeah.
What would you like to add, Seenu? Well, that's my team over there. And they did a great job.
They did.
As they did today. They've been very interactive today as well.
That's cool. So, Seenu, tell us, Centennial Heart, where are you from?
We're in Music City, USA, Nashville, Tennessee, and it's really Health City, USA, too. Many of the major hospital chains and related industries are located and headquartered right there in Nashville or right around Nashville.
So the places I would know there, I've been to Vanderbilt, the university, to do grand rounds before. We've done a POCI there, a Perioperative Quality Initiative in Nashville. And I've also been to HCA headquarters, which are in Nashville too, I think. Is that?
Absolutely. And we're actually right next door to HCA. They're behind Centennial Park, hence our name. We're Centennial Hospital. We're the largest of the HCA hospitals, about 158, and we do have the largest cardiac surgical program, doing about 1,300 hearts a year now. And the other shop in town is a place called St. Thomas, also very famous, very highly regarded. And at one point, back in the late 90s, when I was there as a resident, they were doing 2,700 open heart cases a year.
Wow.
And those were all surgical cases in that era, no TAVRs.
Now, your title's got structural heart in it. Now, I think a lot of people were saying, hang on a second, of course the heart's got a structure.
Yeah.
Tell us a bit more about that.
Yeah, so the concept of structural heart disease as a specialty has really come about with the emergence of certain new technologies. And those technologies fall into technologies that deal not with the electrical system of the heart, like our EP specialists do, or the vascular system of the heart, which certainly our interventional cardiologists do, but really of the structure of the heart. And this would include the heart valves, so technologies such as TAVR, closing holes in the heart with technologies such as ASD device, closure devices, and then certainly in these very late new technologies such as the Watchman device, which helps seal off portions of the heart to reduce stroke risk.
And seal off to reduce stroke risk, is that because there's clots can lurk there, or?
Exactly. Well, we estimate over 4 million Americans now are afflicted with atrial fibrillation. Yeah. And with that irregular heart rhythm of the upper two chambers of the heart, exactly what Dr. Mythen said is we get clot formation. Mm-hmm. And we find that about 50% of the clots due to atrial fibrillation reside in the left atrial appendage. Mm-hmm. So by being able to kind of block that area off, we can have a 50% stroke risk reduction.
Wow.
Now, as part of us all being here, we referred to this in an earlier podcast, but we're sort of celebrating the publication of these new guidelines for perioperative care and cardiac surgery. And I think you're one of the co-authors of it. Is that right?
Yeah. I think I'm fourth author.
And this was published in JAMA Surgery in May of this year.
Yes.
And I think it's been a bit of a blockbuster.
JAMA tells us that. We were just in contact with the editor-in-chief, and she remarked that this has been one of the top articles of 2019.
Oh, fantastic.
Wow. Congratulations.
All times, I heard.
Yeah. Well, it's breaking records. Yeah, for downloads, absolutely.
Yeah.
Downloads. Yeah, congrats.
Now, when we look through it, the main list here of about 20 or so of the items that are recommended with a level of evidence, there's a couple of things that were knocked off the bottom there that had less evidence. Well, we went through it together in prep for this, and we thought many of them were fairly mainstream. Mm-hmm. But there's about, out of the 20, there's about sort of 8 or 9 that are really quite challenging from the point of view of patients undergoing cardiac surgery. And I'm just going to pick a couple out here, for example. The sort of stopping smoking and hazardous alcohol consumption 4 weeks before elective surgery. We all agree, great idea, but that's a hard thing to do, isn't it?
I'm glad you bring that up. It is hard to do, and this is an area that I've particularly focused on with my patient subset, because as I go through elective, as you point out, cases, I really try to make a partnership with the patient. So you're about to run a marathon.
Yeah.
You wouldn't do that without training, right? And I really point out to them, as a partnership between the physician and the patient, it's so important that they do their part. And stopping smoking or tobacco cessation is one of the most powerful single things that a patient can do to alter their postoperative course and outcome. And when I put it in those terms, and then also turn to their spouse or significant other and say, do you smoke? And if they smoke as well, I'm committed to getting both of them to smoke as a team. And we're willing to prescribe the Chantix or the nicotine patch, anxiolytics, whatever it takes. And we do a nicotine test to confirm that.
Do you get them counselling as well if they're finding it hard? Do you put them into
if the resources are available? But really, most patients, when you put it in those and say, Doc, I can do this, the question you really ask them is, have you ever quit before? And you'll be surprised how many have quit. And then you ask them for what length of time. Yeah. So if they're able to quit before for a month, they know they can do it again.
It's very rare to meet a modern smoker who hasn't quit for a while, isn't it?
That's right. And I find that that spouse component or the significant other component, it's who they live with. It's the environment, right? So if they're in an environment where the access now is gone, then they can quit much more easily.
And you've got nutrition in there, and you've got some other prehabilitation elements.
Stuff, yeah.
So it sounds like you're prepared to wait.
On the elective patient, absolutely, because these are powerful things that we know that we can do antecedent to the operation that can then now have a very profound effect on everything that comes afterwards. And there was a nice slide that I think Dan Engelman showed last night that showed the complications in cardiac surgery are really occurring either in the preoperative side, so it's patient selection or patient factors, as you point out, or in the ICU. So these are our touch points.
Yeah, and you can prevent. So one of the other areas is in there is post-operative delirium, which we've talked a lot about on Top Med Talk with the Brain Health Initiative. And it used to be a very, very topical 20 years ago. It was a sort of, and then people seem to go a little bit cold on it because they thought, well, actually, we've investigated the pathophysiology really hard. It's not clear that we made that big a difference from the point of view of emboli reduction or how you run bypass or whatever it is. But it's come back into mainstream because delirium per se, as opposed to the permanent stroke, is really common. Isn't it?
It is. It's not only common, but we find that in a certain subset of patients, it's entirely avoidable or preventable with a few interventions. The other aspect of delirium that I've found is how powerful an effect it is on the family members. I've never seen family members under more stress than when their loved one is in the midst of a really bad delirium episode. The fears are, number one, that they think it's permanent. This is how their loved one's going to be forevermore. Number two, it's the shock to them of seeing them in that state. And number three, how they may do everything from seeing bugs on the wall to absolutely not recognizing someone they've been married to for 30 years.
Yeah.
So it was my stepfather coming from about 20 years ago now, had bypass surgery, and he got home. He did really, really well. He rapid recovery. He got home, he got back into his favourite chair, and I came to see him a few days after getting home. And he was doing the crossword. He used to do the Times crossword, which is hard every day. So I picked up the Times crossword to see if I could help. And it was gobbledygook. So I didn't think he was, post-delirious or anything like that. But and I said, Lisa, none of these... I said, Monty, I don't know. He says, I know I picked this thing up in the morning, and I know I put letters in the boxes.
Oh, my God.
And 6 weeks later, he was getting it right again. Yeah.
Must have been a little hydrocodone effect there, too, though. Who knows?
Right. You hear about that a lot, and, even kind of the silent, hypomania, where they're not having anything at all, and grandma's just sitting there, and they're like, "What's wrong?" And that's really scary too.
So, what simple things do you do? Yeah. What can you share?
Yeah, I think a couple of things is we've really gotten away from the benzodiazepines as a class of drug, no doubt about it. The other component I think that's really helping with reducing delirium is going with the multimodal pain relief approach, because what used to happen is if they're hurting, give a little morphine. If they're hurting still, give a lot more morphine. Yeah. And we know that the primary effect of morphine, certainly there is an analgesic effect, but the secondary effects of morphine would be the post-operative delirium.
Yeah.
For sure.
It's inevitable with the drug, isn't it?
Well, let me ask you, Seenu. So, how did you get involved with enhanced recovery, just in general, and then, your role now in the Enhanced Recovery Society? Can you walk us through that a little bit?
Sure. So, as you all pointed out, enhanced recovery is not really a new concept. It's a concept that I have to say with some degree of embarrassment, our European colleagues were ahead of the game on this. Mm-hmm. The United States does have leadership in a lot of areas of healthcare, but this is one area where clearly our European colleagues were ahead of the game.
Sorry to interrupt, but not necessarily in cardiac.
But not in cardiac. Yeah. That's right. But the concept of enhanced recovery after some type of operative intervention.
Yeah.
So where we wanted to, and this kind of was obviously going on at multiple centers simultaneously. You heard Judson Williams, my good friend here at Wake Med, about 2017. He was just gotten interested in this concept and applying it to cardiac surgery. In my case, actually, HCA Corporate came to me and said, hey, we're hearing about this enhanced recovery in other areas, colorectal. Would you be willing to pilot something in cardiac surgery? I said, absolutely. And so I had to educate myself back in 2017 about what would that look like. And so we gravitated on a few select areas, multimodal analgesia being one of them, delirium reduction being another, and then GI complications, a reduction in those. And said, let's do some interventions and changes in standardization in my patient subset. And then let's do it as a pilot, collect that data, and then push it back out to the group of surgeons. And so now we've adopted it as a group of surgeons.
Now, I work with HCA in London. They're a partner with my NHS trust and work in one of their private clinics. And one of the great things is they're very data-driven.
Absolutely.
And data is very available.
I often joke that they know more about me than I know about myself.
But it just makes it all so much easier, doesn't it?
So today's discussion was just that. I think to really have a meaningful, high-quality center of excellence level ERAS program, it really comes down to what you just said. It's data. It's being able to measure what you're doing and then look at those measurements and then do some iterative improvement.
And you can look at process as well, and
absolutely.
And everyone seems quite financially aware too. Is that they seem to be the fact that it's okay to recognise that what you're spending and the value proposition in everything that you do.
Absolutely.
Yeah. So just real quickly, does STS have a database for? So first of all, let's tell our listeners STS stands for.
The STS, of course, is the Society of Thoracic Surgeons. It's the largest organization of cardiothoracic surgeons, comprised of both congenital heart surgeons, thoracic surgeons, and cardiovascular surgeons. It's an international organization founded here in the United States. One of their most robust contributions to the field of cardiothoracic surgery was the creation over 20 years ago of a database. And what this database is, it was a standardized way of collecting data from episodes of care of cardiac surgery, then thoracic surgery, and now congenital heart surgery. And those are collected at the site that they take place. They're collected by an abstractor, so the surgeon doesn't taint the data. It's not tainted by nurses or administrators. There's an abstractor. The abstraction is done per STS guidelines, so definitions are set. That data is then collected and sent to a centralized place for analysis. And then that data is put into context of how everyone else is doing their work at like facilities and at all facilities. And then that gives you a measuring stick by which to measure your own performance. And basically there's a star rating. and you can be 1, 2, or 3 stars. I think the most important thing for people to realize is 2 stars means you are doing quality work similar to most other institutions in your country or your comparison group. A 1-star means you're doing something less stellar than your peers. And of course, if you're a 3-star, you're doing something better. And in percentage terms, 85% of programs are going to be 2-star.
Yes.
There's going to be very few, really, 10% or less that are going to make it to 3-star, and hopefully you're not that 5 to 10% of group in the 1-star.
And in the 1-star, it's usually that's an opportunity to reflect and turn around and say, what could we do differently here? I
think you're exactly right.
A very positive thing.
Absolutely.
Yeah.
And it's a journey. I call it the journey to 3-star.
And cardiothoracic surgery, as you say, it's been going on for 20 plus years, really ahead of the game in having this available data for everyone to compare themselves. It's been slow coming in other surgeries, hasn't it? It
has been, and it's really what attracted me to the specialty. Over 25 years ago. Was my own interaction with a really amazing cardiac surgeon named John Kirkland in Birmingham, Alabama, who came down from the Mayo Clinic in the 60s. And what Dr. Kirkland was referred to by another famous surgeon, Hank Edmonds in Philadelphia, was that he kept us from being a bunch of cowboys. And what he means by that is he really put some science around what we were doing. And if you look back at his original textbook, Cardiac Surgery, and that's the title of it, what he was doing was outcomes research. He was carefully looking at the operations done in Brisbane, Australia, and there in Birmingham, and compiling those and looking at the outcomes of those children, those congenital operations, and seeing what they could do better and iteratively improving it.
And within the STS database, you're currently reporting acute kidney injury rates?
We're reporting multiple things. We define acute kidney injury and need for new hemodialysis. We look at reintubation rates. We look at respiratory complications. We obviously look at return to the operating room and postoperative infection rates.
Okay,
and quality markers such as the use of the mammary artery. The data-driven.
Yeah. So how is tell us more about the Enhanced Recovery after the ERAS Society, or the ERAS for Cardiac Surgery Society.
So the society formed, about 2 years ago. It was a coming together of thought leaders who really felt this is something that our specialty was in need of. As Dr. Mythen pointed out, this was something that was being done in other specialties like general surgery, colorectal surgery, gynecologic surgery, but cardiac surgery had not put its focus on it because we had kind of come up with this concept of fast track. Fast track in cardiac surgery incorporates many components of ERAS, but not all of them, and certainly doesn't have the same mindset. And the part of ERAS that's amazing is the kind of continual quality improvement aspect of it, the need to iterate, the need to cross-pollinate, and the ability to take new ideas and incorporate them.
Because a lot of people fell in love and fell out of love with fast-track cardiac surgery. Again, it's about 20 years ago. And one of the obsessions then was like getting patients extubated on the table, which was, you're like,
what did that accomplish?
Exactly.
You bought the ITU bed. I mean, as you say in the guidelines, get the tube out within 6 hours, ideally within 4 hours, and usually within 2 hours, but whip it out on the table and then run them around the corner. What's the point?
Yeah, it's kind of like the old adage about making love in a canoe, right? it's doable.
We'll take your word for
it. That's hilarious. Well, Dr. Reddy, tell us, just in closing here, where do you see the ERAS Society going and helping to bring, cardiovascular surgery kind of into this space and getting it going forward?
I think the possibilities are really immense, and I think we're on the cusp of a really big wave. And I think what we're going to see is a much better exchange of best practices. Someone in the room today said the point that we have most of the answers and the solutions. What we have is a problem in dissemination of those ideas. And I think ERAS is going to be a great vehicle to disseminate some great things people are doing in very small focal centers and places around the world, or it's going to put some light on those ideas and allow them to be tested in a much broader sense, and then really find out what we need to incorporate more globally and then standardize it. Dan's vision is that ERAS becomes so global that you could potentially have your operation done anywhere in the world in an ERAS center hospital, and you're going to get a very similar result. I mean, that's really what the beauty of the modernization of industrialization has created for us, right? If you go anywhere in the world and you eat a brand of hamburger, it's going to taste pretty close to the same because they've been able to standardize. If you go anywhere in the world and buy a Dell computer, it's going to work a certain way.
Yeah.
And that's what we need to accomplish in our area.
With the STS database and similar endeavors around the world, which are quite common globally now, you've got the outcome measures, which is what people are often lacking. You've got the risk adjusters. Can you get the process measures in there? Because compliance with elements of enhanced recovery, which I think the ERAS database delivers some of that, is often the missing piece as well.
That's the whole thing, that to get the designation of a center of excellence, that's what you got to have. You've got to process not only validation but monitoring, that those are taking place at all times and they're not deviating from those.
Yeah.
So you've written down 20 elements. Are you doing the 20 elements? Because, I mean, naturally...
And show that you're doing
exactly.
it.
Because I'm guessing people here, almost everyone's going to be scoring about 60%.
That's right.
Yeah.
Anyway.
But it's the 85% that gets you there.
And the other thing is, that we've pointed out to all of our colleagues in there who are on the journey to getting the ERAS, is you don't have to do all 20. It's choose what you think is going to have the biggest impact and do those, let's say 12, but do them well and show that you're doing them consistently.
And in your program, which was the low-hanging fruit that you picked off early?
Well, I think the early extubation rather than on-table, extubation in the 6 to 8 hour range, avoiding reintubation. I think the kidney injury protocol, putting a little bit of a spotlight on that, and then multimodal analgesia. By far, that has been, those three have big impacts.
And the drink, eat, mobilize, is that same as enhanced recovery? You know, get them out of bed, sitting out of bed, having breakfast the following morning.
Yes, not so much breakfast. I think solid food.
What do you go against breakfast?
It's just, well, what about the guy that gets operated on in the afternoon? But it's just any meal. I don't know if it's a solid food issue, but some sort of oral intake. I think most folks have recognized that some type of liquids to get that going, get the gut mobility going, is very important. But I do completely agree with what you say about the eat mobilization. The early mobilization is so important.
Drink, eat, mobilize. Gum chewing, have you played that game?
Yeah, we did that in the pilot, and I think it's absolutely plays a huge role in colorectal type operations. In cardiac, kind of remains to be seen. Probably one of those things that certainly no harm and maybe a benefit.
Yeah, I haven't seen it. Well, Dr. Reddy, thank you so much for sitting down with us. It's been a fantastic conversation, and hopefully we're going to be able to have more of them. If people want to find out more about the ERAS Society, how should they do that?
We have a website, ERAS Cardiac. Please go to it, .org.
Yeah.
And you're going to be having some more regular meetings and love-ins like this around the world?
Absolutely. We're hoping to host one in Nashville this fall. And
excellent.
Definitely, we're really, that's another area that we've grown, is that almost every major cardiothoracic meeting around the world now is inviting us to be a part of it. Whereas 2 years ago, we had to kind of knock on the door and say, may we do it?
And anyone out there has been to Nashville, cool place to go.
Yeah, absolutely. Come see us. Love to have you.
Seems to be popular. Seems lots of people in airports with T-shirts on and pink hair heading out to Nashville for some reason. What's that all about?
Number one bachelorette party destination in the world.
It's not Vegas anymore.
That's right.
It's Nashville.
But great music venue.
Y'all come see us.
We'll be there. Well, thank you. Thanks again, Dr. Reddy, and good luck with everything. You're doing great work.
Brilliant. Thank you.
Cheers.
For having us.
All right.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.